a real privilege for us to have with us Dr. Ameesh Parikh, who is an interventional cardiologist at St. Jude Medical Center. And there have been dramatic changes in the way cardiac problems are being treated today and being diagnosed today. And he's an expert in this area. He did his internship and internal medicine residency at UCLA School of Medicine, and he did his cardiology and a fellowship in interventional cardiology at Kaiser Los Angeles Medical Center, which is where all complicated cardiology problems are referred from Kaiser all over Southern California. And that's where he trained. He's board certified in cardiovascular disease and interventional cardiology. So please welcome Dr. Parikh.
Thank you, Dr. Lawton. Hello, everyone. Thanks for coming. I was asked to give a talk basically updating what's new in my field. And of course, that's a broad topic, but I decided to focus on a couple of novelties, sort of paradigm shifts in the way we approach certain procedures in interventional cardiology. So I'm going to focus on radial approaches to coronary angiography and the transcatheter approach to aortic valve replacement. So I'm going to start by talking about the radial approach. So when we talk about coronary angiography, we're talking about doing a study with contrast dye and motion X-ray, which we call fluoroscopy, to look at the arteries in the heart to see if you have coronary artery disease. And that is when you have plaque buildup that narrows the arteries, which can be treated with stents or angioplasty, and sometimes with bypass surgery. And the traditional approach historically has been to go through the femoral artery in the groin, but the paradigm shift is to approach it through the radial artery in the wrist. So the background on this is that, using the radial approach for PCI, that's sort of the shorthand term for stents and angioplasty, is associated with lower bleeding events when compared to the femoral or groin approach, and less vascular complications. We see that the benefit is higher in patients with acute coronary syndrome, or ACS. ACS refers to patients who have unstable coronary events and end up in the hospital. So that's a spectrum from what we call unstable angina to full-blown heart attacks. And that's to be distinguished from patients who are outpatients that maybe just have stable symptoms and an abnormal stress test, and we electively do the procedure as an outpatient. So there's growing evidence that the radial approach actually improves healthcare quality and reduces costs. It's a format that is growing in the US, although we still lag behind other parts of the world. In fact, in Europe, they came up with the guidelines in 2015 to use the radial approach in hospitalized patients as first line. So if we talk about bleeding from coronary procedures, many trials have shown a wide range of complications with bleeding from the procedures we do, anywhere from just over 1% to as high as 16%. And that variance depends on how we define significant bleeding, the bleeding risks of patients, and what blood thinners they're receiving. But nearly half of all bleeding events from coronary stenting is attributed to the site of access. So in the groin approach, it's a bleeding or vascular complication in the groin. And obviously access site bleeding does have a more favorable prognosis than other sites of bleeding, for example, internal bleeding, bleeding in the brain, but both do increase mortality. So bleeding is important, and what we find is that major bleeding is lower when we use radial approaches to angioplasty compared to femoral approaches. In trials that enrolled both stable and hospitalized patients, there was a benefit, but the benefit was greater in patients that were hospitalized. So patients who have ACS or who are unstable, have heart attacks, they have higher risks of complications and bleeding. So the weighted bleeding rate in the radial approach was about 3.5%, compared to the femoral approach was more like 5.5%, and that was statistically significant. So in other words, for every 1,000 patients that are admitted to the hospital with unstable coronary symptoms, doing a radial intervention will lead to 21 fewer bleeding events. So the number needed to treat to prevent one major bleeding event is only 47 patients. If we shift to vascular access complications, not just bleeding, again, we see lower access complications from the radial approach compared to femoral. If we weight the major vascular complication rate in radial PCI, it's just under 3% compared to the femoral approach for PCI, where it's 7.7%. So for every 1,000 patients with unstable symptoms who are hospitalized, a radial intervention leads to 48 fewer vascular complications. The number needed to treat to prevent one vascular complication is 21 patients. As far as mortality, if you look at trials that enrolled all comers, so outpatients and inpatients, there wasn't a significant difference in mortality. But if you look at just the higher risk patients, those that are hospitalized, that are unstable, we do see a lower mortality with the radial approach. The weighted mortality for hospitalized patients with the radial approach for intervention was 2.7% compared to the femoral approach, 3.7%. So that is statistically significant. For every 1,000 patients that are hospitalized with unstable symptoms who undergo a radial angioplasty, there were 10 fewer deaths. So the number needed to treat to prevent one death was 100 patients. Now, there have been some, opposition, some naysayers that say, well, there are downsides to the radial approach. For example, some older trials suggested that maybe it takes us longer to open up an occluded artery when we do the radial approach. And that seemed to be true in older studies, but less so in newer studies. So I think the fact of the matter is that when we talk about radial approaches, there is a learning curve. It's not necessarily technically easier in the beginning. We as doctors have to do enough cases, familiarize ourselves with the pathways, the nuances of doing the procedure, the tools at our disposal, and it's a different nuance than going through the groin. So in this country, it took us time to learn those things, but as we've learned them and more operators are doing them, we're seeing better outcomes and shorter procedural times. And we really don't see in studies any difference in procedural success when we take the radial approach. If you look at national registries, we really don't see a significant difference in particularly the acute patients with completely occluded arteries, where time is of the essence. Whether we do a radial versus femoral approach, we're seeing similar times of reperfusion or restoration of blood flow. So one of the limitations of the radial approach is the fact that we do sometimes have to cross over. So I could start with the radial approach, I could struggle with it, there could be tortuosities or twists and turns, if you will, in the arteries, technical challenges or obstacles to completing the procedure, and sometimes we have to abort that approach and go ahead and go to the groin. So the real world data suggests that frequency ranges roughly between 5 and 10%. So, when I'm doing an elective case on an outpatient and we choose to go radial, which I most often do, I'll tell my patient there's a 10% chance that we can't complete the procedure through the wrist and we have to fall back to the groin. In reality, I think it's less than that, but I kind of give the worst case number. That number varies based upon our experience. So the more of these procedures we're doing, the more comfortable and confident we are in doing it, the more we know how to tackle obstacles, the greater success we have with it. And likewise, higher volume centers, so centers that are doing more angioplasties, they're going to have less crossover. There are other techniques that can also reduce crossover rates. And then it's been brought up, well, what about radiation exposure? Some people said, well, if you do the radial approach, you might spend more time, you might, use more radiation. And, some data did suggest that could be the case, but again, it depends on when you look at the data. It's a learning curve. So in the beginning, when we're learning to do the procedure, we probably are spending more time, we probably are using a little more radiation, but on one hand, technology has improved. We have more and more tools available. Companies know that we're using these approaches. They're designing more catheters that are favorable for the radial approach. So we have better tools. We have more experience. And most of the time when I do a radial angiogram, I'm using one catheter to look on both the left and right coronary arteries. Whereas when we go through the groin, we're routinely using two different catheters. So a lot of times we'll actually do it quicker and save radiation. So I think we still need more studies, but it seems that this is not such a big concern as some folks might have thought. What about contrast exposure? Again, in the beginning, when you're in a steep learning curve, you might have to use more contrast. You might have to figure out what are techniques to get past certain obstacles or use multiple catheters. But with experience, I've often find that I'm using, sometimes less contrast, especially if I'm using one catheter to look at all the arteries. So I think we still need more data, but there's still not significant data to suggest there's a major difference in contrast. And then what about quality measures and patient satisfaction? Again, limited data, but most patients that I've had, they are more comfortable when we go through the wrist than when we go through the groin. When we go through the groin, even if we use a vascular plug that allows them to ambulate quicker, when you go through the wrist, there's no limitation in walking. We didn't stick the groin. It's okay to bend it at the hip. So I usually tell my nurses to keep my patients flat for an hour after a radial intervention, but in reality, if the patient really had to and wanted to use the restroom 10 minutes later, there's really no reason that they can't. So I think that's a huge benefit. Some patients did report a little more difficulty with self-care activities that use the hand when we use the radial approach. I haven't had so much of that feedback from my patients, but that could be a drawback. But overall, most patients who are surveyed would rather have the procedure again through the wrist than they would rather have the procedure again through the groin. So I think most patients are satisfied with that. And a lot of studies do show actually a cost savings when we use radial approaches compared to femoral, particularly in higher risk patients, so inpatients. Probably because we see less complications, less bleeding, shorter lengths of stay, less need for ICU stays or surgeries or other things that might be needed in complications. So it's a lot of benefits to radial approaches. All right. So I think I'm going to continue my talk on to transcatheter approaches to aortic valve replacement. And then if there's any questions about either of these two topics, I'll take all questions at the end. So when we talk about, aortic valve stenosis, what we're talking about is that, there are obviously 4 valves in the heart, and valves allow the blood to flow forward without letting the blood go backwards. And the aortic valve is the valve between the pumping chamber of the heart, the left ventricle, and the aorta. And that's where the blood that's oxygenated gets pumped to the aorta so it can deliver oxygenated blood to all of our vital organs. The aortic valve is exposed to the highest pressure of all the valves. It's exposed to the same pressure, essentially, as your blood pressure. And it therefore is most susceptible to wear and tear. And when it has wear and tear, it heals with calcium, and over time that narrows the valve. So like Dr. Lawton mentioned about, we have an aging population, people are living longer, we're seeing more and more aortic stenosis. So it's probably the most common acquired valvular disease that we see. And traditionally, that has been treated with open heart surgery to remove the old damaged valve and to sew in a new valve. Well, there has been, again, a paradigm shift where we're starting to do the procedure transcatheter, which means we go through the groin. This can't be done through the wrist. We go through the groin and we deliver a valve through a catheter into the heart and avoid open heart surgery. So this was studied predominantly with the Edwards-SAPIEN valve, which is the major type of valve player in this procedure through the partner trials. So previous partner studies showed that this Edwards-SAPIEN valve was superior to standard therapy in extreme risk patients. Now, to qualify that, extreme risk patients were patients that were too high risk for open heart surgery, and there is no medical therapy, so standard therapy essentially means no therapy. So doing TAVR, TAVR is the term that we use for transcatheter aortic valve replacement, so it's the minimally invasive approach to replacing the aortic valve. So in TAVR, it was superior for patients that were not candidates for surgery. But subsequent studies also showed that TAVR was not inferior to surgery in patients who were high risk for surgery, not too high risk, but high risk, and also intermediate risk for surgery. Over the past decade, there's been further enhancements in the technology. The procedure itself has been refined, and therefore complications from TAVR have been reduced and clinical outcomes have improved. However, these studies showed, okay, TAVR is good for non-surgical patients, patients that are high or intermediate risk, but still the majority of patients we send for aortic valve replacement are low risk. So the question becomes, can we use this technology on low-risk patients? So the first published trial was the Partner 1B. It randomized patients to TAVR versus standard therapy, which really is just treating heart failure, things like that. There's really no medical therapy. 358 patients, that was published in New England Journal of Medicine in 2010. And then Partner 1A came out, randomizing patients that are high risk for surgery to either TAVR or surgical, 699 patients, and that was published in New England Medicine, 2011. Then they did intermediate risk for Partner 2A, again randomized 1-to-1 TAVR versus surgery over 2,000 patients, published in 2016, New England Journal of Medicine. And now we have the Partner 3 trial, randomizing low-risk patients to surgery versus TAVR. They included 1,000 patients. So what does that show? So the purpose of this Partner 3 trial was to compare the safety and effectiveness of the TAVR approach versus conventional open heart surgery in patients who have severe symptomatic aortic stenosis but are at low risk for surgery. So the design was to capture these symptomatic patients. Low risk was assessed by a heart team, and they use a common morbidity and mortality score that's used by surgeons to counsel patients on the risks of surgery. And it was defined as a morbidity and mortality risk less than 4% from surgery. They were randomized to either TAVR or traditional surgery, specifically with a tissue valve. So none of these patients received mechanical valves. And follow-up is at 30 days, 6 months, and then annually until 10 years. The primary endpoint of the study was to look at what is the composite of any cause of death, strokes, or rehospitalization for cardiovascular reasons at 1 year after the procedure. So they enrolled 65 sites in the US, including Hoag locally, Canada, 3 sites in Japan, 1 site in Australia, and 1 site in New Zealand. These were the top enrolling sites, and you can see that actually Cedars-Sinai was one of the top 5 enrolling sites. So they did include patients who had what we define as severe aortic stenosis, so it's a little bit technical, but when we do ultrasounds of the heart or an echocardiogram, we can calculate the valve area. If it's less than 1 centimeter squared, that's consistent with severe. If the peak velocity across that valve is more than 4 meters per second, that's consistent with severe. If the mean or average gradient or the pressure difference from the ventricle to the aorta across that valve is at least 40 millimeters mercury, that's considered severe. So these are our usual definitions when we read echoes. Also, they either had to be symptomatic, class 2 or more, or they had to have a exercise stress test where they developed severe shortness of breath, an abnormal blood pressure response to exercise, or an exercise-induced arrhythmia, or if they were asymptomatic but their heart function was reduced, which is an indication to replace the valve, then they could be included. And again, they had to have a low surgical risk, which was determined by a multidisciplinary team and then adjudicated by a review board. So very strict, vigorous criteria. They did exclude patients based on certain findings. For example, if the size of the aorta where the valve is placed, we call the aortic annulus, is too small for the smallest valve, or too big for the biggest valve, then they couldn't include those patients. If a patient had a 2-leaflet valve instead of a 3-leaflet valve, they were excluded. Having a bicuspid or 2-leaflet valve is actually the most common congenital heart disease that we can see. Likewise, if they had a severe leak in the aortic valve or the mitral valve, they were excluded, or if their heart function was severely reduced. It is rare, but some patients can have a very thick chunk of calcium in the outflow tract of the left ventricle below the valve, and that's a risk for rupture. So if they have certain criteria of that, they had to be excluded. So every one of these patients gets a CT scan, and that looks at the valve, it looks at the aorta, and it looks all the way down into the blood vessels in the leg, because like I said, the procedure is done through the groin, and it's a huge delivery system, so we need an adequate, healthy, adequate size, straightforward artery that's not overly tortuous. So if they did not have the vascular anatomy that we need to perform the procedure, they were excluded. Likewise, if they have severe and complex coronary artery disease that couldn't be treated with stents, they could not be included. So when we do TAVR, if a patient also has coronary artery disease, we have to take care of the coronary artery disease with angioplasty before they can be a TAVR candidate. The other thing with these valves is that they are a bit bulky. They have stent struts, if you will, and so if the coronary arteries have a takeoff from the aorta that's too close to the valve, there's a risk that the TAVR valve can obstruct the coronary arteries. We don't want that. So we can actually measure that distance on CT scans, and if it doesn't meet the criteria, they're excluded. Similarly, if they had a recent heart attack, recent stroke, if they're on dialysis or have stage 4 or higher kidney disease, if they had unstable heart rates, blood pressures, or breathing, or met a frailty index, then they were excluded. So this just shows you some evolution of the valve over time. There's been some slight structural changes. More importantly, the sheath compatibility has gotten progressively better. So you can see that we're using these huge, up to 24 French sheaths, and it's down to 14 to 16 French. That's still quite large. When we do radial angioplasties, we're using 6 French sheaths, so it's still substantially larger than what we might use for PCI, but it's gotten improvement over time, and that's huge because the bigger the catheter sizes, the more the risk of complications and bleeding from the vascular access. And additionally, the sizes of the valves have increased over time, so we started off with only 2 sizes, then 3, and now in the PARTNER 3 trial we have 4 different size options. So, again, every patient was reviewed by the heart team and the review board. Every patient had a 30-day assessment for neurologic status by a neurologist and serial neurologic assessments. And if there was a concern, they had neuroimaging. All patients had 3D cardiac imaging done, like I mentioned. And in some cases, they would allow the PCI or stenting to be done at the same time as the valve. Most often we do it beforehand. Or in the case of surgery, if they had concomitant coronary disease, they could get bypassed at the same time as the surgical valve. All right. They also got echocardiograms to monitor the valves. So the primary endpoint was, again, looking at all causes of death, strokes, or rehospitalization for cardiovascular reasons at 1 year. The first analysis they did was to make sure that was TAVR inferior or non-inferior to surgical approaches. If TAVR is non-inferior, then the plan was go ahead and see is TAVR superior to surgery. So this is just some statistical jargon, but basically whenever a trial is designed, there are certain statistical analyses that can be done based upon known numbers and some assumptions that are made to calculate how many patients do we need to enroll in this trial to meet the, to be able to prove the primary or disprove the primary hypothesis. So based upon the calculation, they needed at least 864 patients, but they actually ended up enrolling 1,000 because sometimes you do lose patients to follow-up or patients withdraw or other things happen where you lose data on some patients. So they defined what is non-inferior with the safety margin and the typical statistical analysis that we use in these kind of studies. So they ended up consenting 1,520 patients that had severe symptomatic AS and were low surgical risk between March 25th of 2016 and October 26th of 2017 at all 71 sites I mentioned. 520 of them had to be excluded based upon the preoperative evaluation, sometimes for anatomic or clinical or other reasons, or incomplete screening, leaving us with the 1,000 that were eligible for enrollment and which were randomized. Quite fairly evenly here, TAVR 503 and surgery 497 patients. Now there were some patients that, some patients unfortunately didn't survive till the procedure, some had to be excluded after they were randomized, some of them withdrew, but still pretty robust numbers. 496 patients initiated the procedure for TAVR, 454 for surgery. So that left 950 treated patients, still well above the number they needed for the trial. One of the TAVR patients had to be converted to an open surgical procedure, and one of the surgical procedures had to be aborted. But overall, over 98% follow-up for the primary endpoint, which is very good. So this just shows that basically if we look at different characteristics of the patients, they're pretty much the same in the two groups. This is important when we analyze statistics, because what if you have older, sicker patients in one group than the other, and the reason for differences in outcomes is because the patients aren't as alike as we would like. And this basically shows that they are actually quite similar, so good results that we want to see that prove that whatever we find is not based upon differences in patient characteristics. Again, looking at baseline echo and CT scan findings, quite similar, because again, what if, one arm of the patients have sicker hearts, lower heart function, worse valves, worse other findings in the other valves, etc. That's not the case. These patients are very similar. These numbers are very similar. So these are some of the findings. Obviously, we use conscious sedation for TAVR, whereas general anesthesia is used for the surgical patients. Obviously, the procedure time is a lot shorter with TAVR compared to surgery. There's certain things that are done in surgery, like cross-clamping the aorta or having cardiopulmonary bypass, which doesn't apply to TAVR. The average ICU stay was statistically longer with surgery, 3 days versus 2 with TAVR. The average total length of stay in the hospital was longer with surgery, 7 days compared to 3 days with TAVR. And more patients with TAVR were sent home after the procedure, 96%, whereas some surgical patients might have had to transition through a skilled nursing facility, so only 73% of surgical patients were able to transition home for self-care. And more often, surgery required other associated procedures than did TAVR. As far as complication rates, we're not seeing a difference statistically. Maybe the access site infections kind of jumps out here in surgery at 1.3% compared to 0.4% in TAVR, but the statistical analysis shows it's not statistically significantly different. So similar complications in the hospital. So looking at the primary endpoint, 15% of patients met the primary endpoint here at 1 year in the surgical arm, and 8.5% met it in the TAVR arm at 1 year, and the difference was 9.3% and 4.2% at 1 month. So we actually saw lower composite of all-cause death, stroke, or cardiovascular hospitalization in the TAVR arm, and that was statistically significant, and this shows that TAVR was not inferior to surgery. And then they did the statistical analysis for superiority, and it was actually highly statistically significant at 1 year that TAVR was superior to surgery. So this is looking at just all-cause mortality. Though the all-cause mortality trended to be higher in surgery than TAVR, it's not statistically significantly different. However, if we look at all strokes, there was a statistically higher stroke rate in the surgical patients. Not only that, there was a higher rate of death or disabling strokes, not just mild strokes, but very significant or fatal strokes was higher with surgery. And this is the rehospitalization, again, statistically higher rehospitalization with surgical patients at 1 year. So this just basically says intention to treat, not how they were actually treated, but if we intended for them to have TAVR or intended for them to have surgery, you basically see almost the same numbers. So this just shows that basically what if we take subgroups, what if we look at specifically men versus women, they're all low risk, but relatively higher risk compared to the lowest risk patients, or differences in heart function or symptoms, or even whether or not they had AFib. Across the board, we see that the subgroups tended better with TAVR than surgery. So there wasn't a difference really in different subgroups. Some other things that they looked at was new onset of AFib. We do often see AFib after open heart surgery, so it was almost 40% in the surgical arm and 5% in the TAVR arm. Again, longer lengths of stay with surgery, higher primary endpoint with surgery. So these were the statistically significant differences. Looking at some other outcomes, again, just to analyze differences between surgery versus TAVR, most of these things were not different. Bleeding, including life-threatening or major bleeding, was actually higher, both at 30 days and 1 year in surgery, and that was statistically significant. This other one that's statistically significant is a new left bundle branch block. So basically what that is it's an electrical finding on the EKG. So we are seeing that more patients with TAVR, based upon the way the valve is put in and sits, in its location, can affect the electrical system so that you develop this left bundle branch block pattern on an EKG. It happened in 22% of TAVR patients and only 8% of surgery patients. That was statistically significantly different. However, many patients have left bundle branch blocks and it doesn't cause any symptoms, it doesn't portend to poor outcomes. So it's really quite a benign thing. It's not leading to pacemakers or anything like that. So to me, that's, it's worth noting, but compared to major life-threatening bleeding or something like that, this is really quite a trivial thing. Now we can look at the differences in the average gradient across the new valve after surgery versus TAVR, and we are seeing a statistically significant difference, but the difference is very small. Okay, an average gradient of 10 to 15% is excellent after surgery, but we're seeing an average with TAVR of 13.7 millimeters mercury versus surgery 11.6. And that probably just has to do with the fact that we're putting a valve within a valve as opposed to excising the old valve and sewing in a new valve. So there's going to be just a very small difference there, but that's not clinically significant. Same thing on the opposite end. If you calculate the valve area, just very slightly lower valve area with TAVR than surgical, again, for the same reasons that I would expect, which is barely, it is statistically significant, but I don't think it's clinically meaningful. This just shows you some of the distributions of sizes that were used between surgery versus TAVR. And whenever we do a valve replacement, there's always a chance we can have some leak around the valve. Now, when you sew in a valve surgically, you should get less leak around the valve than if you put a transcatheter valve in. So that's what we're seeing. There is a statistically significant difference at both 30 days and at 1 year of what we call paravalvular leak with TAVR compared to surgery, which I think is expected, but worth noting that difference. But if you look at patient symptoms, patients were more likely to be symptomatic 30 days after surgery than they were 30 days after TAVR. So I wonder if some of those symptoms are just related to the recovery from surgery. You're going to be probably more easily fatigued, more easily out of breath, going through a major operation like that after 1 month than a simpler operation. So, I don't think it's necessarily a difference between, the quality or the valve itself, but it's worth noting that patients felt better sooner with TAVR, but that difference really went away at 1 year. So at 1 year, there's no difference in how they felt. It just took longer for patients to get there with surgery. Similarly, the 6-minute walk test, at 30 days, patients are able to do it much better with TAVR than surgery. The numbers are still better with TAVR than surgery at 1 year, but statistically, there's no difference between the two at 1 year. And same thing with the quality of life type of score, how patients feel. It's more a subjective assessment of their health was better for TAVR at 30 days, but really not different between TAVR and surgery at 1 year. So patients felt better in both arms, it just took longer with surgery. So what's the conclusion of the trial? That, the designers of the trial concluded that for a population of severe symptomatic aortic stenosis patients who are at low surgical risk, TAVR, when compared to surgery, demonstrated superiority in the primary endpoint at 1 year and 6 pre-specified secondary endpoints. And that was shown after they first proved non-inferiority. We saw that there was a significant absolute reduction in the primary endpoint of all cause of death, strokes, or cardiovascular rehospitalization at 1 year, an absolute reduction, a relative risk reduction of 46%. So the findings favor TAVR at 30 days and 1 year. And a lot of analyses were done to show that the data is quite robust statistically. And then, of course, patients felt better sooner, like we mentioned. We talked about the 6-minute walk test and patient scores, questionnaire scores, functional status, and also that patients went home more often from the hospital and sooner than with surgery. So based upon these findings, the researchers concluded that TAVR should be considered the preferred therapy in low surgical risk aortic stenosis patients, that over the past 12 years, the partner trials have clearly indicated the benefit of the TAVR approach, independent of surgical profiles, and that the choice of TAVR versus surgery should be made with a shared decision-making process involving patients, doctors, respecting patient preferences, ideally using a heart team approach. I think that one thing I would caution you is that this is 1-year data. So we don't have 5-year, 10-year data yet. We will be getting that. The trial is going to continue to analyze this data, and it'll be interesting to see if we continue to see these kinds of benefits from TAVR versus surgery, if any other concerns with TAVR come up in terms of longevity. But so far, the data is very promising. So that's the fourth part of this piece of the puzzle. So the timing actually was impeccable for this talk, because it just so turns out that while this has been a work in progress really ever since I think I joined St. Jude a couple of years ago, finally we did our first TAVR cases last week at St. Jude. Previously we were doing those cases over at St. Joseph Hospital. So as of today, we are now doing TAVR here at St. Jude, and those cases, I'm told, went very well. So that's all I have for you today. Thank you for your time, and I'll take any questions. So the question was, what are the symptoms of initially having heart issues? So if we're talking about TAVR and SAVR and aortic valve, the symptoms of aortic stenosis are exertional chest pain, or basically angina, shortness of breath with exertion, or potentially even having outright congestive heart failure, and exertional dizziness, like a lightheaded, faint feeling, or even outright exertional fainting, we call syncope. Does that answer your question?
So exertional mean when you're exercising? Or?
Right, so exertional means when you are active, when you're doing things that get your heart rate up. Okay, other questions?
Yes. What's the p-value?
The p-value is a value that is used in statistical analysis to say, if you have two numbers, how do we know that they're actually meaningfully different? I mean, I can look at one number and another number and say, they look different, I think they're different, but is it actually meaningfully different? So the p-value is the way that we determine that statistically. So if your p-value is less than 0.05, then it means that difference is statistically meaningful. If it's greater than 0.05, then statistically there's no difference. Regardless of how different those numbers might look to you, statistically they're not different if the p-value is greater than 0.05. That's an excellent question. So the question is, I'm talking about TAVR for aortic stenosis, which is the narrowing in the aortic valve. Her question is putting in a valve for a leaking valve totally different? Well, it's a different sort of problem in a way. There are some technical differences, but as doctors, we send patients for surgical aortic valve replacement for both reasons. So I think that when you're designing a trial like this, it's easier for them to focus on one specific pathophysiology, but in reality, we are already doing TAVR for leaking aortic valves as well. It's just that it's not been studied in this way. So some of those may be off-label. Yeah, so that's going to be a clinical decision on the part of your cardiologist. The question was, when I'm talking about mortality, was it during the surgery or hospital stay or down the road? Most of those slides we're talking about down the road, so it depended on the specific slide. I think I had a slide that basically showed there wasn't a major difference in complications in the hospital. So during those 3 days of TAVR hospital stays or 7 days of surgical hospital stays, there's not a huge difference in the outcomes. But when you look at mortality, strokes, cardiovascular rehospitalization at 30 days, which was the primary endpoint, and again at 1 year, that's when we see the differences. But again, those differences were predominantly based upon strokes and rehospitalization. The mortality rates on that one slide that I showed weren't actually that different between the two arms. So the question was about whether TAVR is better than surgery, and the mention was also about strokes. So again, this data in the PARTNER 3 trial for low-risk patients, right, suggests that even in low-risk patients, at 1 year, TAVR so far is better, it's superior. And that's based upon the composite endpoints. And one of the major driving forces of that difference was strokes. So according to this data, we are seeing more statistically significant strokes from surgery than we are from the TAVR. The question was, how do we know your hospital is using TAVR? So until recently, it wasn't so many hospitals that were doing this, but actually recently there has been a rapid uptick in the number of hospitals that are doing these procedures. But the only way to know for sure is to really probably talk to your doctor, or possibly, you know, I don't know if the websites for the hospitals might have information, or I'm sure you could, you know, directly contact the hospitals by phone and find out whether they have a TAVR program. But we are doing this here at St. Jude. We're doing it at St. Joseph. We're doing it at Mission Hospital. I mentioned Hoag was one of the trial centers for PARTNER 3, and Cedars-Sinai obviously was not only one of the trial centers, was one of the top 5 enrolling centers. So those are some of the places in this area. And there are, I think, maybe a couple of other smaller hospitals that are doing them. Yes, the question was whether Kaiser is doing it. They are actually. When I was a fellow at Kaiser, I had scrubbed into one of the first few cases there, and so they are doing it. When I was there, they were using predominantly the Medtronic core valve. The PARTNER trials are based upon the Edwards SAPIEN valve. I think they're both good valves. They have good data behind them. I would expect similar outcomes with the Medtronic valve, but this particular data was with the Edwards SAPIEN. Edwards SAPIEN is probably the most commonly used. I know that for us, at the time that we've been doing it at St. Joe's, both valves have been used. And sometimes there can be some nuances or benefits to one over the other, but I'm not sure if nowadays Kaiser is also using Edwards SAPIEN or not. I haven't had that communication with them recently, but yes, they are doing that.
What about UCI?
The question was about UCI. I believe that UCI must be doing TAVR, but I don't know for 100%, but I'm almost certain that they are. So the question is whether calcification of the coronary arteries and the valves is inevitable, and whether anything can be done to reduce that. So they've looked at a lot of studies for aortic valve stenosis in terms of medical therapy, because again, we would love if we could have a medical therapy option to prevent or delay progression of aortic valve stenosis, which essentially is progressive calcification of the valve that narrows it. And in all the trials that looked at that, they looked at, controlling blood pressure, controlling cholesterol, controlling, usually the usual risk factors for heart disease. They found no benefit. The thing is that calcium isn't the principal problem. The principal problem is that there are, if you will, cuts and bruises, nicks and wear and tears that occur to tissue, be it the arteries or the valves, that requires these tissue structures to heal. And when they heal with calcium. So calcium is the hallmark of atherosclerosis. So as we age, atherosclerosis will affect every single one of us. There's no way to prevent it. So, for example, when we do chest X-rays, we can see calcification of the aortic knob very, very commonly. And depending on the age of the population we're looking at, the older the population, the more prevalence of that type of calcification. So, we still recommend all your basic, healthy, heart-healthy diet, exercise, controlling your risk factors, but it's not really proven that that's going to necessarily prevent calcium buildup. Risk factors like diabetes, high blood pressure, high cholesterol certainly accelerate atherosclerosis and therefore increase risk at a younger age for things like heart attacks and coronary artery disease. So we want to treat that. But just to mention, calcium itself is not necessarily the main problem with coronary artery disease. I know people do focus a lot on that, but I've had many patients with very, very high calcium scores that really don't have significant plaque buildup, don't have significant narrowings, and while we assume that that's a higher risk for things like heart attacks, many of those patients do very well. So, it's a hallmark of atherosclerosis, but it's not necessarily the focal point or target of treatment. The question is, what would be a concerning resting blood pressure? This is sort of a moving target, but historically we would have said if you're 140/90 or above, then that's stage 1 hypertension, and if that cannot be lowered with lifestyle modification, then should be treated to reduce cardiovascular risks. There is some schools of thought out there, some published documents that suggest perhaps, the concern of blood pressure should vary based upon age. So there are times where we might accept, in older patients, a blood pressure less than 150/90. So some of it's going to be a little bit of a judgment call on your doctor's part. It's going to be a little bit based upon your own history, willingness of the patient to take medications, response to medications. There's a difference between a patient taking a low dose of a medicine, no side effects, achieving a beautiful blood pressure, versus a patient where you're struggling to bring the pressure down, they're not responding well to meds, they're having side effects from meds. So, it's a lot of individualization of care, but in general, we're looking at 140/90 or above, is of concern and should at least be discussed with your physician.